Hello, everybody. My name is Linda D'Onofrio. I'm a speech language pathologist, and I am also the administrator of the Oromyofunctional Study Group. Oh, I think I may be now live. I haven't done this before, and while practice might be a really good piece of advice, it's not usually one that I take very well. So this is my first office hours for the Oromyofunctional Study Group. And I hope this works out really well. And if it does, and people find this of any value, we will do a few more of them. So I'm just learning how to do this now. And so as people join the live event, I will see you in the chat. And Natasha, whenever you join, please come in and write a comment, and then I will add you as a guest and I will know that you're there. But until that happens, I see that she's live. Again, I could have practiced this, but that wouldn't be very exciting at all. So we're going to talk today a little bit about generalizing things that you learn in a myofunctional program, and the most important of those being how to swallow your spit and what to do with your tongue when you're doing nothing at all. So as people join, I'm going to slow down just a little bit because I do want to see if I can grab Natasha. And there she is, my darling. Let me see if I can add you. And let me see if I can bring you back up a little bit and add you as a guest. So please forgive me for this little bit of, hi. Hold on a second. I got to catch up and we got to see if I can add you on. This seemed really easy in another place. So as people are coming in, let's see if I can just click on you, my darling. I want to stay on this page. And if anyone has done a Facebook Live event and knows how to add somebody as a guest to this, please jump on and make a comment. I'm already sweating and we've just barely started. But until then, what I'm going to do is I'm going to just introduce myself a little bit more, and I'm going to then allow Natasha to introduce herself. And if we can't get this going live, I may have her talk a little bit in the chat, but I will do most of this because I don't want to make her do a lot of typing. So let me see, again, if I can invite her to join me. And I don't see it on the three dots that go to the left of the person. All I see is that I can see comments right now. So let me see if I can edit this and if I can invite somebody a different way. Tag a friend and let's see if we can do this. Okay, so I don't know how this is going to go. This might just be me today. And if it is, we might go do this a little bit short. So this is about swallow your spit. The reason I wanted to invite Natasha, and she is a member of the study group, is she's an adult. She's a physical therapist. She's very well in tune to her own body. And she was seeking me out for help pre and post a surgical procedure and orthodontics. And so one of the conversations, she lives in another country, and so we're really working in an online fashion, and telehealth is now sort of how we're all doing it. And this was my first online evaluation. We actually had to do it over a number, I think 2 sessions. And we've only talked to each other sporadically through this process. So there has been no weekly therapy. There has been no formal therapy program. She is an educated medical provider, and I was providing consultations to her, and then she would reach out to me whenever she needed me. So let me see. I've got a couple of people on here, and I'm going to see if I can get her back on here again. So let me see if, and again, if anybody that's watching has any experience with adding a guest and to a Facebook Live event, and I'm not changing through Zoom, Natasha, we're not stopping now, girl. We're moving through this today. So let me see if I can just come back here. If we can't get her as a guest. What we may do today is just do this for about 15 minutes and then open it up to questions. And then I will schedule this at another time where she and I can share screens and do this side by side. I still prefer to do this in the study group rather than on our own individual timelines, which I know this works on profiles, because we have a larger audience in the study group. And if we can make this work, then that would be my preference, but we'll see how we do. Hi from Peru, hi to Peru from Oregon. Hi, David. Okay, so, and again, David and anyone new that's starting, if anyone knows how to add a guest to a Facebook Live event here in a study group or in a group, let me know, because there's nothing on the screen that generates how I can just add someone. I'm afraid if I push on Natasha too much, I'm just going to go to her webpage and kill this whole thing. Okay, so the question that made me want to do this office hours today is when I talked with her on, I do believe, Tuesday of this week. She said something to me that I hear all the time. It feels like my tongue is too big for my mouth. I don't know what to do with my tongue. When I try to put my tongue tip up to where it's supposed to be, it feels like the whole rest of my tongue is going down my throat. And no matter what I do, it doesn't feel comfortable and it doesn't feel like I'm doing the right thing. Hi, Natasha. Sorry, I'm still working on it, girl. So as I began asking her what she was doing, because this conversation comes up, it's either the first thing a person says when they walk in my office, my tongue feels too big for my mouth, or during the course of therapy as they're learning about elevated lingual resting posture, as they may or may not be getting a lingual frenectomy or going through orthodontics or another procedure, they're struggling with what normal is supposed to be and how they're supposed to do it. So please forgive me going back and forth, because I'm trying to also deal with these messages and see if somebody's helping me share this screen with Natasha. So the conversation really was about lifting the tip, optimal rest posture, having full lingual palatal contact, and how you're supposed to make that work if that's not what you're used to doing. I just heard somebody click in, so I don't know if anybody figured out the screen share yet. So if you, I am going to unpin it and see how that works. Okay. This conversation and these concepts work if you have perfect facial morphology, if you have a high narrow palate, if you've never had orthodontics, if you're post-orthodontics, if you need a tongue tie release, if you're never going to get a tongue tie release, everything that I'm going to kind of talk to you about and what I talked to Natasha about on Tuesday is the same. The initial focus feels like it needs to be on the full tongue reaching the hard palate, and to a large degree that's true. But what can change it is where the pressure focus is. And in talking with Natasha, she was talking about pressurizing the center part of her tongue, and she felt like the tip kept falling down. And every time she would bring the tip up, it would literally push the tongue back in her mouth, which is not our goal in any way, shape, or form. So as we were having this conversation, one of the things that I sent you a message and a screenshot. Well, I can only see the message you just sent, Christina. The screenshot won't come in unless you sent the message somewhere else. And I don't see Messenger lighting up, so I don't know where the message would be other than here. That's the only place it can be. So I'm not going to jump off and get that. Well, maybe I will since she's so smart here. And it just says, I can't read all that. So if you can't tell me, I'm just going to keep talking. As I was saying, it's about pressurized focus. And for speech pathologists who work with voice, there is a technique and a concept in voice therapy about vocal focus. And you can focus things in your nasal cavity. You could focus things orally. And you can create a vocal mask and you can project. Vocal focus is a known technique. As Natasha was talking to me about lingual pressure, I wanted her to consider her lingual focus. because as she was talking to me, and Natasha, if I'm wrong, please, because since I don't have you on a screen, jump in and just tell me that I'm completely frying this. Her focus was mid-blade, getting the middle of the tongue up, thinking that that was where the goal was. And my advice was to change the focus from mid-blade to the tip against the alveolus. When I was first trained in myofunctional therapy, tip to spot was what was taught. And it really kind of ignored the whole rest of the tongue. I mean, it was basically an L. The tip was up, but the sides could be down. It wasn't really so much an N where the tip and the sides were up. And it certainly wasn't with lingual palatal suction. I'm going to jump over to Christina one more time. I see lots of pretty screen pictures, Christina, but I can't stop and read any of those. So again, if you don't type and tell me what to do, I'm just going to keep moving on and ignore your messages. Okay, so the tip to spot had some real legitimacy, because when you go to swallow your spit, and as I talk about this, I talk about saliva swallows all the time because they're the ones that matter. But when your tongue tip goes to your alveolar ridge and you initiate a correct swallow where that tip does not fly off, but is stable, the rest of the tongue goes exactly to where it's supposed to be. It doesn't slide back into the throat. And so tip to spot, that concept really comes in when people don't know where that lingual focus, and I'm sorry, Christine, I'm just killing that because I cannot do that right now. Tip to spot really has legitimacy in resetting where lingual focus should be. So if any of you have a little spit going, and sorry, darling, I can't do this right now. So in fact, I'm just going to turn off Messenger and I'm not listening to those anymore. Okay, so if you have something in your mouth, whether it's a little bit of saliva, whether it's a drink of a bit of liquid, you really only want about a teaspoon of this for this experiment. And I've been talking all day, so I don't have a lot of saliva. When that tip is anchored into the alveolar ridge and you initiate that swallow with lingual palatal pressure, the tongue will expand up into the hard palate and it won't push forward, it won't push laterally. If that lingual focus is too far back, think about a centimeter or two back, that tongue tip will still have a kick and it will still pressurize into the teeth. The corners can pressurize into the cuspids and into the lateral incisors. And certainly, if you lose full control, you can have a full frontal and bilateral thrust. Okay? So when Natasha and if you're still here, darling, just say hi on the comments and I'll know you're still around. The conversation we were having is the tongue doesn't just go back and forth. It doesn't just contract and just stretch. It does far more because it has muscles that go long, it has muscles that go wide. It can contract and it's hydrostatic and actually can become three-dimensional in shape. My hard palate is extraordinarily narrow with a very large torus in the maxilla. And I can still get most, I would say 85, 90% of my tongue within my dental arch in a vertical push when I swallow. If you focus anywhere else, the stability changes. And I'm doing downward dog with the tongue. Yes, that was it. Thank you, my darling. That was the conversation. We were trying to find analogies. And one of the conversations we were having is she does yoga. And that there are positions that when you're new to yoga, when you're new to an exercise program, when you're new to dance, when you're new to anything, you kind of get it, but there's little finesses, there's little pieces that you need to pick up later. So one of the things in talking with Natasha, she was concerned that she wasn't doing it correctly at all, and that wasn't the case. She was mostly there. Most of the tongue was up, where in the old days, the tongue wasn't up at all, and it was all pressurized into the teeth. These days, tongue tip was elevated, still into the teeth, but what an improvement. And instead of trying to pull the whole tongue back, we were talking about the finesse. in a yoga move like downward dog, if anybody is familiar with it, which is kind of hard, especially if you have tight hamstrings. You really don't look great in that pose for a long time. And you can also change where that focus in that pose is. You can push back into your heels and try to get them down. You can come up on your front and bring more of the weight into your arms. So that when you're thinking about even resting posture, when you're thinking about initiating the swallow, there really is play in that lingual focus. And so if you get lost, if you're working too hard, and when I work with adult women, they often internalize this and think about this too much. We start with a swallow, tongue tip goes to the rugae. It's always easier if you close your molars and contract your masseters the tiniest amount, but you don't have to, and initiate the swallow. The swallow will pulse vertically, up into the hard palate, front to back. The other thing that we talked about was contraction of the tongue tip versus moving the entire tongue. When you play with the sound difference between S and SH, and I don't know how well the camera will pick this up, but I don't have to move any other muscles of my face other than my tongue tip. And I'm not moving the whole tongue back in order to achieve the SH component. All I did was contract, and I can't do it with my fingers because my fingers are not hydrostatic, they're bony. But all I did was contract the tip. And in an adult face, that's less than a centimeter, okay? The tip is contracted. And so as I was talking with Natasha about modifying this positioning, instead of pulling the whole tongue back to get the tip to the rugae, she may very well be in the right place posteriorly and only needs to bring her tip a little contracted and up into those rugae. And so again, it's a play. It's a play on pressure. Oh, and I want to remind you, I want to thank you for reminding me. Natasha shared that when she had first learned about swallowing and tried on her own, she was contracting and rolling the tongue a little bit too tightly. Kids do this all the time when they bring the tongue too far back. And then they try to swallow, which you can do, but it's not natural and it won't work and it won't stick. The feeling should be N, except we had a little problem with Natasha. In American dialectical English, most of our alveolar sounds really are lingual alveolar. Na, ta, da, la. Even our palatals, cha, ja, are only a little contracted. They can be alveolar as well. But that is not true. And by the way, that also extends then to sa and za, also lingual alveolar sounds. But that is not true in everyone because Natasha doesn't have English as a primary language, and French and Spanish have lingual dental contact for a lot of sounds. So for American kids, I'll often call resting posture the N posture. And I couldn't do that with Natasha because she's not Natasha, she's Natasha. And so what we learned is the lingual alveolar sounds for her are lingual dental sounds. And I don't know, because of where she's from, because Nova Scotia, I hope I got that right, if that's dialectical, if that's a byproduct of lingual restriction, if that's habitual from decades of low forward resting posture with articulation. I'm not quite sure what the genesis of that is. It could be a combination of any of them. So as we were going through our session, and I think this was a 45-minute online session. Oh, Quebec, thank you for keeping me honest. I don't know if that causes a fight. Is that fighting? I don't know. In Texas, that could start a fight if you tell somebody that they're from the wrong school or the wrong town. So as we were going through the session, what I wanted her and want everyone to really think about is getting lazier, not working as hard on this task, actually working less. And if you get a little saliva in your mouth, if you get a little spit, and you literally just stabilize. And again, if you just close your teeth gently, you only need to stabilize the tippy tip of your tongue. You don't have to stabilize all the way around. That required me to hold that liquid and keep a very tight end posture. Saliva doesn't really require that, but we do swallow our spit over 1,000 times a day. So how we do it matters to the generalization of all our goals. Barbara, the tongue resting like a pillow, I think that's a really great analogy. Haven't thought of it as a pillow because I work with kids who are really intense, and and adults, but I often talk about that pressure, that lingual palatal pressure, which isn't necessarily a pillow, but it could be. I think that works just fine. For me, there's a pillow tongue rest posture between the molars. And I see that with a lot of women with facial pain. So when I think of a pillow, I don't think of it. I think of it between the teeth is where my brain first goes to. So Natasha, if I left anything out, please jump in if there's anything from our session that I left out before I go on with this. And please jump in and interrupt me, and then we'll do questions. We have a lot of Canadians or people who really like Canadians here today. Yay. They're so nice. I can't be I'm not nice enough to be a Canadian. Okay, we'll edit that out later. Okay, so where I'm going with this is in myofunctional programs, there's this idea about strengthening, there's this idea of building symmetry, there's this idea of building stability, there's goals and objectives within these myofunctional strategies. But all these exercises and all these techniques are really only so you swallow your saliva correctly every time. And don't pressurize your teeth. Always pressurize the inside of your palate. Pressurize from a front to back. And when the swallow is over, your tongue stays right where it was. So that after the swallow, the tongue remains in the hard palate. And with a tongue thrust swallow, it never remains in the hard palate. And so every time I watch somebody, if someone takes a drink, the tongue bypasses the hard palate, lands right back in the mandible. And then you have to reinitiate rest posture. I often do. Thank you very much for taking me in Canada. They might be kicking me out of the US just any day now. So, but instead of trying to reinitiate rest posture, what I tell people is reinitiate the swallow. If you want to remember what you're supposed to be doing, smile, swallow your spit, and move on. And with children, with adults, I don't set this up as a regimented exercise. I've just never seen this be really successful, making a subconscious behavior a conscious behavior. I like to keep it subconscious and teach covert techniques. So I often teach just little triggers. With my adults, as soon as you get into the car and put the key in the ignition, your tongue tip should come up to your erugae, you should swallow your saliva, and you should move on. If you're on a computer and you finish a task, the second you hit that return key, the second you close that tab, your tongue tip comes up to your erugae, you swallow your saliva, and you move on. With children, when they're reading books, I always say when you get to the end of that page and you flip that page, that's likely a good time to swallow your spit. And since most of us have to swallow our saliva every couple of minutes anyway, when the phone rings, when you know you're about to do something voice, we often have extra saliva that we swallow right before we say hello. We don't even realize it. It's a perfect time to set that rest posture, set that swallow, and then start. So, uh, well, I'm working on Bulgaria. We'll do a little, we're doing a live, Facebook Live event for Bulgaria on Sunday. And hopefully I'll learn how to get people on a screen by then, because clearly it's not happening in the groups unless there's some magic thing that I don't know about with adding somebody in a group. I will play with it on my timeline later on. Okay, where I'm going with this is people work too hard at this, and they really should play more gently at this. And when especially adults take on a task, they forget that you learn better through more naturalized tasks. We're so used to formal lists and protocol and formal ways of doing things, and it's not a way a kid learns ever. When I'm doing this with children, if I had kids in my clinic right now, I could be sitting across from somebody playing a game of Connect Four. We could have juice or anything out next to us, and in between our turns, we're just taking sips of liquid. We both have mirrors in front of us. We can swallow our spit, watch to see if there's any perioral pressure, which is how you know you did it right. So if your tongue tip is down and you guys have any ability to see each other on your own screens, if you purposely swallow with your tongue tip down, it will look obvious. It has obvious perioral pressure. I never can get the third one down. That pressure is a vacuum, and you see it as it's trying to create a vacuum and remove the water from the space. The tongue should be the muscle set that takes all that pressure, and there should be nothing on the face to show. And so it's a discrete saliva swallow. That's how you know you're nailing it. So I tell all my patients, I tell everybody, what you do when you do nothing is the most important thing you do for growing a face. And if you're doing nothing, mouth open, you'll be paying somebody to regrow that for you later. If your lips are your face's braces, your tongue is your palate expander, and it stays there quietly, swallow after swallow, where it really matters is where you sleep. Because if you're laying there and initiating at the alveolar ridge, the tongue will eventually just stick to the hard palate because your spit's got glue in it. And it won't fall into your airway because it can't. And every saliva swallow will reinforce. And so it's not an exercise, it's a technique, I guess. But it really is something that I want my patients and folks playing with from the very first day they meet me, every single day. And if they're adults, I hate to break it to them, they might be working on it for a while, but most of my kids won't. And the way you know you've nailed it is just put a video on yourself and just watch yourself read a book. If your face doesn't move, you probably did it right. I watch little kids swallow, eat all the time. And I always joke, restaurants are my zoos. And I can watch and see a lot from 10 feet away. All right, Miss Natasha, I feel like I've ripped you off and not let you be part of this. So we're going to have to figure out another way to invite you. But please, if you're still around, can you send a comment and let me know if there's anything that I forgot from our session? Because I think I wrapped up a 45-minute session in about 30 minutes of chit chat. And if she doesn't have questions, then Barbara, if you are still looking and helping, if you saw any questions popping up. But otherwise, I'm happy to start taking questions and comments about rest posture, about swallowing, and answer questions. So, oh, okay, this one from Jared that's right here. Okay, the question is, one client removed the oh, is that it, sir? Okay, that's a fantastic swallowing style if I nailed it. So let me answer. One of the clients, the majority of his lower lip. Okay, so my first mission, if I see a bottom lip disappear, the first thing I want to see is what's this jaw relationship? Because that's not the only time that happens. Because it is not easy, even with my bite, for me to suck my bottom lip into my teeth. But if I have 7 millimeters of an overjet, maybe if I was a thumb sucker and I bent in my bottom incisors and canted out my top incisors, and if my resting posture was an F, then my swallow still has to have a vacuum. I still have to close the hole to make the liquid go. And if my tongue tip can't close the hole, and my lips don't, my bottom lip will do it. And this is what this swallow looks like. Fantastic, really. And every single swallow bends the bottom incisors in more and jacks out the top incisors a little bit more. So when I teach this, the first thing we sometimes do is have a party for the bottom lip. And the reason we have a party for the bottom lip is because it's been doing a really hard job for a really hard time, and it wasn't its job to do. It was a different part of the anatomy, but the kid didn't know that, and the kid really wanted to swallow. So the kid figured out, if I suck in the bottom lip, I can close it off, I can create a vacuum, I can swallow, there goes dinner. Nailed it. And of course, you know, I don't know how old this patient, but you know, I can see this in a 10-year-old, no problem. But the first thing we have to do is teach the correct swallow with the tongue tip. Because a swallow is a reflex, that bottom lip is not going to stop helping with the swallow for quite some time, because that's what a reflex is. The story I often tell, and it's not politically correct, so it doesn't fly everywhere, so I don't know that I'd share the story with everybody. Well, I'll share it with you because y'all are my friends. My brother and I used to wail on each other and fight quite a bit. And we used to play a thing called the punch game. And the punch game worked if I was walking down the hall and he scared me and I jumped and I had a reflex, he punched me. Now, it worked both ways. If he walked down the hall and I scared him, I had to punch him. Very lovely game. But one day the game ended because I walked down the hall and he jumped out and I didn't have a reflex. The reflex had just been desensitized. Reflexes can be desensitized. It's a trick. You do have to learn it. And that bottom lip will jump in. So I always tell kids that we need to have a party for that bottom lip and thank it so much for helping. And it's going to want to help for a while. And it's going to forget that it's not part of the reflex that you've done 2,000 times a day, 365 days a year for the 10 years that you've been on this planet. And now I want you to do something different for the rest of your life. Okay? So as you teach that, I teach it with a lot of humor. I teach it with a lot of failure built in. But that's just part of a reflex. And as soon as the tongue does the job, that bottom lip, that jump should relax quite a bit. So Jared, please let me know if I answered your question. And okay, Natasha jumped in and said that I had commented on her swallow when I was watching. Well, you're not going to see it on me unless I do this. So let me give you the laptop neck, the thing women should, I guess, never do when you're on a computer, because this ain't pretty. But I can see quite a swallow here. So let me, hold on a second. Okay. Oh, I'm totally out of spit. Hold on. The lighting isn't really great, but I can often see, let me see if I can do it from the side for you instead of from the, but I can often see the mechanics of a swallow while people are doing it. I can tell if there's a tongue thrust, woman doesn't open her mouth. I can see the pressure into the front of the face. I think it's just because I spend a lot of time watching people swallow. I spend a lot of time watching people chew and eat. And not everybody does it the same way. Not everybody does it in the same kind of face. So that was sort of when I was watching Natasha, only because she kind of had the laptop down. I said, oh, I saw that great swallow you did. I could see it because I could see the musculature of the tongue rise up to the hard palate when she did it. Okay, I am happy to answer any other X-ray vision. Yes, ma'am. Natasha, anything else I can answer for you? And Jared, okay, thank you. I got his question. I'm happy to answer any other questions about your lingual rest posture, teaching it in children, teaching it in adults, saliva swallows. And again, when I talk to kids about sucking up flat, let's just talk about this exercise. The whole reason that exercise exists is just so you swallow your spit properly. Okay? Every exercise, if I do use them with a patient, belongs to an objective and belongs to a goal. I'll get to that one in a minute, darling. Thank you. But if I don't know why I'm doing an exercise, I'm not going to do it. And the reason I teach sucking up flat and sometimes incorporate a slurp swallow or some sort of small mechanical swallow in there is only so that it generalizes to saliva. And in speech pathology, an argument and a philosophy, which I think has real legitimacy about if you want to get better at speech, you need to teach speech as opposed to doing exercises. And that sort of is part of the fallout in speech pathology about oral motor. And I think it has legitimacy in the same way that if you want to learn tennis, you really should practice playing tennis. Lifting weights might make you stronger, but it won't necessarily translate to tennis. And I feel the exact same way about these exercises and techniques. Saliva is the most important thing you're ever going to swallow. When you're unconscious, you do it. When you're asleep, you do it. When you're in a coma, you do it. So doing it right is important. And it's the only thing that is, it doesn't matter if you get through a whole program, but you really haven't generalized oral resting posture. What you do when you do nothing is the big win in this. Natasha had a comment about an unimportant tongue thrust. This is a question or a comment I get and a concern from people all the time. Oh yeah, it's just a small tongue thrust. It's just a little tongue tie. It's my daughter has a very minor lisp. Oh yeah, it's a little tongue thrust, but it doesn't mean anything. That's like being a little bit pregnant. You are or you aren't. It does or it doesn't. It is or it is not. There is no severity in its existence in the function, in the structure. It's in the function. But if you have a small tongue thrust, every tongue thrust swallow is pushing the TM joints back into the fossa. Every time the tongue presses forward into the teeth, the back of the jaw presses into the face. Conversely, every time the tongue presses into the hard palate for a swallow, it opens the TMJ and creates space. So what I want my patients to know is when they see a little kid with a tongue thrust swallow, that is not benign. That is a potential future adult patient in facial pain and other issues. When you see a little lisp, it's an indication that tongue is not in the right place for other things too. That's just the canary in the coal mine. So there's no such thing as a little or a minor or a mild. Those words have no real meaning. They have no measurement, and they don't have any real clinical definition. For ankyloglossia, that is different. You can absolutely grade the structure of that tongue tie, and you could give a quality of life severity scale. I've had kids who choke and vomit on meals. I've got 5-year-old twins that prior to their lingual frenectomies were vomiting daily at their dinner table. Okay, that's severe because the functional impact was severe. But the structure of their tongue tie itself wasn't necessarily up to the tip. it wasn't considered a class 4 or a type 1 or any of those grades. So I hope that answers that question a little bit about tongue thrust. Hey, Manol, you were right. I can't share a screen in groups. I don't know how to do it, and I'm still learning. So you were right. Practice is important, and people should do it before they go live on the internet. Oh, well. Okay, so we are still going on. I'm happy to answer any other questions. Oh, hey, everybody, I like that we got dentists there. I always like dentists. So any questions about evaluating rest posture, evaluating swallows outside of speech pathology, or generalizing it even more? I mean, I can talk about more than just spit, but this is called Swallow Your Spit. But I am hoping to keep office hours at least for another 20 minutes. And so I'm happy to just answer any questions that folks have about function. Oh, hey, Manol, you had a great picture of a woman on your timeline. And I think that might actually be another sort of quick thing we can talk about. Oh, wait. Oh, I'm going to let Barbara jump in first. Sorry. When do we swallow with teeth contact and when do we do it without? Oh my gosh, do you want me to fight with everybody? Am I right to say during rest, swallowing is without teeth contact and with deglutinate? That's the best word I've ever heard, deglutinate in a bolus of food. It's called eating. You're eating. You're eating a bolus of food. Okay. Yeah, is the answer. Most of us have what's considered freeway space, okay? Not everybody. And the reason folks don't have freeway space is multifactorial, okay? And if you've got a bunch of ground down teeth and you're 50 years old, me talking to you about normal resting posture is not like me talking to a 5-year-old. But let's pretend right now it's a 5-year-old. Yes, most of the time we have a little bit of freeway space. And frankly, your teeth don't need to touch if you're maintaining normal lingual palatal rest posture. Hi, Phil. Because if you are, your jaw floats. When your tongue is suctioned to the roof of your mouth, you can hold your mouth together without contracting your masseters and clenching your teeth. People think they have to keep their teeth closed because they don't know any other way to keep their mouth closed. So they use masseter compression and molar compression. And that translates into daytime clenching. I often meet a lot of women with very overdeveloped masseters because of that. So when we swallow, yeah, you can have your teeth touch. You don't have to. It depends on what's in your mouth. And if you're deglutinating something really chewy like a steak or some kind of meat that has tendinous fiber that goes through it, I don't look like a purple troll. That's so. I'm sorry. Wait. I'll get my troll. My purple troll is actually at the house the other day. Where are we at? We're chewing. Often that last chew is, yes, the beginning of a swallow. I'm going to have to be more professional on these next time. I'm going to have to stop ignoring everybody over here and just keep talking like a grown-up. But that'll be next time. It's not clearly not going to be this time. Okay, so yes, but I don't give rules about that. I don't think I've ever told a patient what to do with their teeth. I've certainly answered that question when patients have asked me. But unless I'm seeing masseter activation, I'm not about teeth contracting. So I know, really. I do. I gotta stop. So I don't really worry about that so much. I know that's a big conversation with dentists because I actually, for fun, started an argument in front of a room full of dentists on that. I knew what I was doing, but I didn't think everybody would take the bait. But I didn't also appreciate that. I guess, I don't know if there's a paper written on it, but certainly this has been a topic somewhere, either in a textbook or something, that teeth should touch, except when chewing. That actually I was taught in a dental course, is that teeth should touch at rest, but they don't actually touch when you chew. And that's a topic for a different day, I think. Okay, so no, I don't look like a purple troll. Okay, thank you, Dr. Chu. I appreciate that question. Um, Happy to answer another one. Anybody got questions about rest posture, getting a good spit swallow on, how to evaluate it? I might have cheek retractors here somewhere. One of the ways, the fastest, easiest way to evaluate this is truly with cheek retractors. Let me see if I don't wander off too far, if I can find some. I've got a lifetime supply now since I won't be sticking them in anybody else's mouth. But this is often how kids used to get referred to me from orthodontists anyway. Oh, Arlene, in just a minute, darling. Don't tell anybody I'm doing this. Okay, so here is my all right. And if I swallow my saliva, this is a Christmas game now, right? Okay, you couldn't see any of it. However, if I was good and thrusty, let me get a little bit more, wet my whistle here. There's a swallow. Okay, so I can watch it. And often at a dentist's office or an orthodontist's office, the child or the person in the chair simply cannot initiate a swallow at all without perioral pressure. So they can't even get it going. You'll see them pumping and pumping and pumping, trying to make the swallow happen. And often they'll have to sit up, swallow, and then put the cheek retractors back in. And in the old days when I used to teach orthodontic assistants and dental hygienists how to make a referral, this was one of the signs and symptoms is, can they initiate a swallow with cheek retractors in? So there is, I know, and that's right. Okay, so that's how I can sometimes evaluate it. But honestly, I want every orthodontist and every dentist I know keeping saltines in their office. I love saltines if you are not gluten intolerant, because gluten sticks. And I'll often ask a kid to eat 3 or 4 of these without a cup of water. And I just sit back and watch the fireworks, because usually about the second or third cracker, that starts kicking in. So whether or not you work with food, because not all of us have food in our scope of licensure, dentists are not necessarily doing feeding therapy, but using food as a screener or an eval, I think, can tell you so much about your patients that you don't know. And for the sake of repeating myself, for all you school-based SLPs out there who don't know if you're working with an articulation kid or a myofunctional kid, the fastest way to figure that out is to watch them eat. I used to say back when we were all in school, go to the cafeteria. If that's an articulation kid, they'll be closed mouth chewing and looking pretty decent. And if that kid is open mouth and smacky, that's not an S kid. That's a myofunctional patient. Okay, so we have what advice? Oh, thank you, Marlene. I'll get to use now. What advice would you give to snorers if there's no tongue tie and no apparent ENT issues? Mouth snoring, nasal snoring, or pharyngeal snoring? What are we doing there? That's a nasal snore. That doesn't require a tongue tie. That's a uvular snore. That's my, excuse me, my tongue falling into my airway. I don't have ENT issues, and it didn't require a tongue tie for me to do any of those things. So it's not that you snore. I want to know why you're snoring or why that patient's snoring, and I want to know how they're snoring. Again, nasal turbulence has nothing to do, well, it can be an obstruction, but it can also be over breathing. You could simply be creating turbulence by breathing at too high a volume through your sinuses. But certainly there could be structural issues, but I don't know that an ENT is the person. It could be an oral maxillofacial surgeon. I'm not entirely sure on that. So it depends on the kind of snore. I don't have to have a tongue tie to have my tongue fall into my airway. I just have to be a mouth breather all day and then be a mouth breather at night. The tongue's going to go into the airway. It's just a matter of time. Excuse me. Took one for the team there. Hold on a second. Okay, so I guess I'd want to know why this person is snoring. So I want to back a little bit and make sure that I answered Marlene's question completely. So, oh, Miss Cornejo, that's my sister, Merida Cornejo. I love that last name. So please tell me, Marlene, if I answered your question entirely about snoring, because there's other factors. I mean, weight is a factor, age is a factor, overall health and vitality is a factor. I mean, I worked in nursing homes. Everyone in the nursing home snored. Might be why they were in a nursing home is what I've always wondered. Okay, so let me get down. Oh, nasal snoring. Okay, so sorry about that. My first instinct would be to check for a deviated septum. Many of us have deviated septums but don't have broken noses. We don't see it on the outside, but it does exist on the inside. I would also be curious about overall face and neck weight because it's a factor. And then I'd wonder about other things. I mean, if I stay out really late and I drink too much alcohol and I don't tape, I sound like a train. But if I go to bed at, regular time and I haven't had a lot to eat and I, close my mouth when I sleep, I don't snore. So snoring is multifactorial, a lot like reflux can be. So I hope that helped a little bit. Okay, Barbara, I'm gonna let you're driving here. So from Nicole, tricks to have posterior portion of the tongue remain on the palate at rest. Oh, that was Natasha's question too. Thank you, that's a brilliant question. And let's assume we're talking about adults with high narrow palate. Okay, let's just go there. You don't, is the short answer to this question. If, okay, in my mouth, and I don't, let's see if I can get something going on here. I don't know if it's gonna work. I'm a disaster. Ha ha ha. It's very narrow. There's nothing, there's no space, there's nowhere to go. And for most of my life, even though I had an elevated rest posture, the back of my tongue was way, way down, okay? I have been practicing this for over 20 years. I've got a high, narrow palate. I didn't get my tongue tie fixed till like 4 or 5 years ago, although it was completely torn and stretched. At rest, 50% of my tongue tip is up and 50% of it is down at rest, always, because it is too high and narrow and it doesn't fit. But when I swallow my saliva, it completely goes to my hard palate all the way to my uvula, and it stays there for a bit. Not very long, because the inside of my mouth is a disaster. And there's no way a suction cup's going to stick in my palate because my palate looks like that. It's narrow with a torus. There's no way lingual palatal suction is going to last. And it just slowly begins to tear away. Now once I got my tongue tie fixed, I'm able to keep more of my tongue up, but still, I'm never going to 100%, except for every time I swallow my saliva. And then I go back and I do it again. So in a child, this really matters because I've seen palates that are quite wide in the front that tent in the back, and it is a byproduct of posterior tie. So depending on the age of the patient, now really tricks, it's that sucking up flat. That's all I can do is make deep, dark Ks. Now I can swallow saliva while I do it. It's still up there, I can feel it. But I know, because I spend way too much time paying attention to things going on inside my body, that it eventually is going to start pulling away. So not everybody gets perfection. Early intervention matters, and the sooner you get a hold of a face, the better. And for some of us, what we do is compensation for the rest of our life if we don't make other structural changes. if I had non-surgical maxillary osteogenesis, or if I had a maxillary surgery, then that would be different, and I might not even have to have a trick to get my posterior tongue up, because everything would fit. I'd have like a 3-car garage instead of this little 1-car garage that I've got. Okay, so hi Robert. Oh, hi Robert. Hope things are good in Florida. A lot of myo exercises, very good daytime. Oh, dude. Ugh. Okay, my son still sleeps with his mouth open. We tape in, and he loves it. Why he's not converted to closed mouth posture? Let me see what I don't know. I don't know. I don't know the answer to this, because I know that you guys have been on this because we've talked. I bet we talked about a year or so ago. Okay. I don't remember how old your child is, but I don't think he's a teenager. My memory of your boy is that he's a preteen. So there's a bit of me that wants to know how many years before he learned myofunctional techniques and how many years it's been since. Because what if you guys are still doing okay and it's just part of this process, and I can't answer this right now. And I don't know what's happening in his sleep, but there's a little bit of me that's kind of tempted. I would, if you guys have any way of watching sleep to see what happens in the middle of the night. I don't know if it's a byproduct of living in Florida. Is it a byproduct of humidity? Is it, I don't know the answer to this, Robert. I wish I did. And I'm going to be thinking about this more, because I think it has to do. Oh, he's 10. Thank you very much. Oh, it's early days yet. Okay, so you guys have been doing this for about a year and a half. Is corrected broad. Okay. Well, yeah, there's this idea. Okay, so the question was about nasal turbulence for him too. Is he also overbreather, which I think is a great question. And oh yay, I'm glad the open bite shut down. That makes me happy. Okay, so how about we keep working on it? Kids are always moving targets. It's very hard. Okay, you know, I always joke, kids don't go through phases and they never outgrow things. I don't know who starts these rumors, but they're always changing, moving targets. And so literally once you teach a kid a skill, if they're behind, there's already another skill they're supposed to have. So if he had 8.5 years of this other behavior, and you guys have been working on this, you guys might be on a good path. You're just not at the end yet. So yeah, I don't disagree. Heather's suggestion was maybe about some breathing re-education during the day. That's not an idea at all. But I don't know. I don't have a great answer on a kid that I don't know any more about than that. I'm sorry, I don't have a good question, a good answer for that. All right, boys and girls, do you want me to keep answering questions? I can wrap up. I don't want to leave anybody hanging. So if there are any questions that I haven't answered, otherwise, I guess I need to go learn how to do this so that we can make guests in a different way. I guess I'll get to Kelly there. I owe Manol an apology because he wanted to do something I thought was really complicated, which was try to do Zoom on Facebook Live. And I thought, that's so silly. Starting to look really good. Okay, Miss Kelly, low for courage in a 2 to 3 year old. Well, one, airway okay is not a diagnostic thing, so I don't know. Low forward tongue posture has 3 etiologies, and really only 3. Airway obstruction, soft tissue restriction, or something has been in that mouth. And that's what brought the tongue low, and it needs to come up. So airway okay is not airway fantastic. And so my first suspicion is always about airway. So a 2 to 3 year old, I'm curious about nose blowing. I'm curious about closed mouth postures. Even if the tongue is the tongue low, mouth open, or is the tongue low, mouth closed? Those aren't entirely the same things. And okay, if you guys have to go, I appreciate it. Thanks for stopping by. I'll be announcing other office hours at another time. Now, how I teach this, though, is I teach it through tongue pops with little ones. In is starting that game of the elevated posture. If I am seeing good movement during eating, good lateralization, good cleaning, then I wouldn't make that part of my goal, but I would be suspicious if the tongue is low and forward. Why? And what else is going on with a low forward tongue? Is it in the mandible when the child talks? Hi, I want to go to the store. No, I don't want to. Is the tongue low in the mouth when we're eating? Or is the tongue just low at rest? So that answer, one, I think if the bony structure is normal and muscle function is normal, you should be able to teach that kid. But there's a reason the tongue's down, and I don't know the why the tongue was down in the first place. So finding out the why to the what is definitely how to remediate it permanently. When I was first in this field, I was trained in tongue thrust. I was trained to remediate oral habits. I was trained to correct speech. And that is the symptom. And I never questioned why those symptoms were in front of me. And I never looked to solve the reason that those symptoms existed. So when I think about this little 2 to 3-year-old, the first question is, why? Before I tell you what to do, why is it there? So Miss Kelly, if you've got more to add on that one, I'd be happy to extrapolate on that a little bit more. So, and I'm happy or answer a different question. Barbie, you got anything else going on? Hi, Dave. Nice to see you, sir. Hope things are good up in Canada. We got a lot of Canadians today. Oh, well, because it's morning. No, that's Australia. It's morning. Same time in Canada. Okay. If anybody has any other questions about lingual rest posture, about swallowing your saliva, about assessing it, about treating it, let me know. I am going to hopefully do these once a week. I would like to bounce around. We've had some requests about, hi Sherry, about also doing some on Monday, and that's to accommodate some folks who are observant and don't work on Fridays. And so I may bounce around and do a few Friday ones and a few Monday ones. But I'm also more than happy to take future topics. So before you guys leave, would you please throw in the comments a topic you'd like to talk about for a future office hours? And I will absolutely set this up, and we'll just pick a topic, tear it apart, grab some books, if I can plan ahead of time, we'll get some video on patience or whatever you might need. And Natasha, I owe you a huge apology to set you up, and then you didn't get to come play with me, and I'm sorry I didn't get the screen sharing set up. But I will learn how to do this, and it will be better next time. Okay, y'all. I'm going to say, let's see, Okay, be able to answer this. Oh, last question, best one. You can have gigantic tonsils in a nasal breathing child. It is the most astonishing thing you'll ever see. You can have a kid walk in your office that has 3+ tonsils and the mouth is open and the tongue is forward. You can literally see tonsils that are touching, a uvula stuck between them, and lips closed around it. Excuse me. But what you see is almost irrelevant because the tonsillar tissue can grow down the throat. And if you're only seeing a 2, that's all you saw. You have no idea what they look like in the oral pharynx. And frankly, they could be big fat 3s, but be very deep. So I had a set of twin girls, 7-year-olds. They had shark teeth, double sets of teeth, that giant tonsils and adenoids. And only one ended up being the tonsil and adenoidectomy. There was another medical issue with the second child, and she didn't get the surgery at the same time. And so her sister never got her tonsils and adenoids out. And I can't wait to follow them over time, because I know we're going to see craniofacial differences over time, because I know that soft tissue will, I mean, that hard tissue will continue to grow around. The soft tissue, the most impressive thing was the twin who got tonsils out, her breath was so much better than the twin who had her tonsils, because she had halitosis from tonsils all the time. So, okay.